Hello and welcome to the recall session for this July 2023 FMGE examination. Here we are going to have a discussion on the orthopedic recall questions. The paper was lengthy, the paper was tricky but as far as this orthopedic section is concerned, all the questions were relatively easier and just in a single line, you might have come up with the answers. Alright. So in this recall, what we are going to talk about means how you have identified the question in particular. Like there was a question which was mentioning that there is a history of injury to the arm with resultant fracture in the mid 1/3 of the humerus and the patient was not able to extend the wrist. Now everything was provided to you in the question. You just have to sum that up, that what is the name of the nerve which is likely to get injured and what is the name of the nerve injury that has resulted in this kind of the outcome. All right. Now all of us means this is not for the first time we are talking about it. Like if this is the humerus bone, the name of the nerve which is lying in closed approximation to this humerus in its entire length, right from the medial aspect up to the lateral aspect before its division into two of its terminal branch, the name of the nerve is radial nerve. Now this is something which we already know about, right? It is radial nerve. Then if there is a fracture in this mid 1/3 segment, and because the nerve is passing from the spiral through the spiral groove, right? So there is always a possibility of impingement of this nerve at this level. And once there is an impingement of this nerve at this level, that is in between, that is mid 1/3 of the humerus, then it will result in a high type of a radial nerve injury, as a result of which there will be inability to extend the wrist, as well as there will be inability to extend the metacarpophalangeal joint. So straight away means all of you must have answered this question right. Like if mid 1/3 of the humerus fracture is provided to you, they are asking about the name of the nerve which is likely to get injured, the name of the nerve which is likely to get impinged in this segment, that is a spiral groove, all right, is the radial nerve. So this means it is something, this is the kind of the question which all of you must have marked correctly, all right. Coming on to the next question. Now, this is the kind of the question which we have discussed multiple of the times with a hint. Whenever we have talked about a scaphoid fracture, I told you 3 points that you have to remember. Point number 1 is the hint which will always be provided to you in the question clinically if they are asking this question. And that is, there is a tenderness in anatomical snuff box. That means anatomical snuff box tenderness. All right. Now, all of you are aware that this anatomical snuff box tenderness, there are 3 differential diagnoses. All right. One of the differential diagnoses is obviously the scaphoid fracture. The second differential diagnosis is de Quervain tenosynovitis. You already know what is de Quervain tenosynovitis. It is the impingement of abductor pollicis longus and extensor pollicis brevis in the first compartment of extensor retinaculum, as a result of which there will be a pain and tenderness which is elicited over the first this anatomical snuff box. So de Quervain tenosynovitis. Then apart from this is the fracture of the radial styloid. All right. Now, what are the things which are provided to you in this question? They gave you a mechanism of injury, fall on outstretched hand. Also, scaphoid is fractured when there is a fall on ulnarly deviated arm or ulnarly deviated wrist. So it can also result in a scaphoid fracture. But there is an anatomical snuff box tenderness. Now, once it is provided to you in the question that the patient is having an anatomical snuff box tenderness, you are ready with these 3 differentials. As far as options are concerned, in the options, they are providing you the name of the carpal bones. And then they are asking what is the name of the bone which is likely to get injured. So the name of the bone, obvious answer for this question is scaphoid. It is a scaphoid fracture. Now, as I told you, 3 points that you have to remember. One is anatomical snuff box tenderness. The second point that you always have to remember related to this particular topic are the complications. All right. The complications are avascular necrosis, also the osteonecrosis, means one and the same thing. So osteonecrosis of the proximal pole, which is far more common compared to the distal pole. That means one of the complication is osteonecrosis in the body of the scaphoid, and the second one is the non-union at the fracture site. All right. And the third point that you have to remember is related to the management. Management means if there is an undisplaced fracture of the scaphoid, then there is a peculiar cast, a particular cast is provided in order to immobilize this scaphoid fracture for the elongated or extended period of 8 weeks. The name of the cast is scaphoid cast, and it is also known by the name of handshaking cast. But this is not the treatment for displaced fractures of the scaphoid. It is for the undisplaced fractures of the scaphoid, all right? Not for the displaced fracture. It is glass holding cast. It is glass holding cast. So everything we have already talked about, like why is it called by the name of glass holding cast? Because of the immobilization of the wrist in dorsiflexion, immobilization of the thumb in abduction. So it gives it a position, it gives it a shape of as if you are holding a glass, all right? Undisplaced fracture of the scaphoid, the complications you should be knowing about, and the most important fact, that is anatomical snuff box tenderness. So everything is provided to you in the question. You just have to mark the correct answer for the purpose of its identification. All right. Next question. Now, this is the kind of the question which is considered to be new. All right. Possibly the first time ever asked question. Now, they are asking that what is the name of the nerve which is likely injured, resulting in this kind of a deformity or abnormality. So, first of all, you have to identify the abnormality. When this is a kind of the image where the back is revealed, then majority of the time, the first thing that you try to sort out is look at the level of the scapulae, because one of the condition that you are aware of is a Sprengel shoulder. Sprengel shoulder is high-lying scapulae, one of the scapulae which is incompletely descended scapulae, and as a result of it, there will be asymmetry of the scapular margins or the scapular borders. But here, there is no such asymmetry. That means one of the differentials that you tend to see on the back or region, one of the differential is Sprengel shoulder. But here, because Sprengel shoulder is identified by asymmetry of the scapulae, here there is no such asymmetry which is observed. So Sprengel shoulder obviously is not the answer for this question, because both the scapulae are at the same level. Now, the second thing that you tend to see when these kind of the images are provided to you is the winging of scapula. And how this winging of scapula is identified? It is the medial border of the scapulae on the affected side will be more prominent in comparison to the normal side. But there has to be an observable push which should be provided in the question. As if the patient is trying to push the wall, then only there will be an over prominence of the medial border of the scapula on the affected side. But here, there is no such over prominence of the medial border of the scapula on the affected side. So possibly this winging of scapula is also not the answer, where this back is studied. Then the third one is scoliosis. What happens in scoliosis? It is a lateral curvature of the vertebrae. It is a lateral bending of the vertebrae. Now, in this case, the vertebral column is exactly in the center. All right. There is no such deviation, no such lateral deviations which are observed in this back also. So, scoliotic deformity is also not there. There is no such scoliosis observed. Then, what is the abnormality which is obvious in this case? The abnormality is that if you look on the left side of the patient, all right, this shoulder border, the posterior border of the shoulder, that means the trapezial border of the shoulder on the left side is asymmetrical in comparison to that of the right side. On the right side, there is a lower level of the trapezial border compared to that of the left side. And in the question, there was a history of stab injury in and around the neck also provided. And this thing happens that the 11th cranial nerve, that is spinal accessory nerve, is likely to get injured under the influence of either compression or because of the stab wounds, leading to the paralysis or the palsy of the trapezius on the affected side, as well as that of the sternocleidomastoid on the affected side. As a result of which, the contour of this trapezius is lost over a period of time, and there will be an asymmetry observed at the level of the shoulder. All right. So, one of the shoulder is sunken down just because the trapezius on the affected side is not functional or might be paralyzed because of the injury to the spinal accessory nerve. So, what is the fourth thing that, as a fourth differential that is important for you to identify, is that the trapezius on the affected side or the trapezial border on the affected side is lower. There is asymmetry on the posterior border of the shoulders, all right, right from the neck. And this asymmetry, the reason for this asymmetry is the spinal accessory nerve injury. All right. Now, although the question is concised, like which structure is most likely to get damaged, but the language of the question which was provided in the paper was that there was a history of a stab wound also. All right. stab injury, and as I told you that the mechanism for these spinal accessory nerve injuries possibly is because of either a stab or a compression injury. So answer for this question goes in the favor of spinal accessory nerve, that is 11th cranial nerve. You already know that 11th cranial nerve is responsible for the supply to the trapezius and sternocleidomastoid muscle, right? And here in this case, the trapezius on the right side is paralyzed, as a result of which it is responsible for creating this asymmetry. Yes, an important question for future. And whenever there is an image of this sort is provided to you, then these are the 4 differentials that you have to rule them out one by one. The one thing is winging of scapula, but for winging of scapula, there has to be a push movement like this, all right? And this entire thing has to be captured in the picture. Second is spranger shoulder, where the shoulder level has to be, or the scapula level has to be higher in comparison to the other. The third one is the scoliotic deformity, where there is a lateral curvature of the vertebrae. And the fourth one obviously is the trapezial palsy, or you can say the spinal accessory nerve injuries, all right, asymmetry of the shoulder. So hopefully you have marked this answer correctly. Out of all the questions which were asked in orthopedics, it is a kind of the question which was considered to be a new one. Otherwise, every other question was a repeat one of the sort. All right. Now, this is something which we have talked multiple of the times, and there has to be no confusion as such in order to identify these lateral deviational abnormalities at the level of the elbow, right? Normally, all of you are aware of the fact that if this is the trunk of the individual, this is the arm of the individual, this is forearm of the individual. So we are having the axis of long axis of the arm, long axis of the forearm. Now within normal limits, there is a deviation, and this deviation is known as carrying angle. But on the other hand, if this carrying angle is increased in comparison to the normal, all right, that means there is more deviation towards the medial aspect, that the apex which is being created is more inclined towards the medial aspect, then this abnormality is known as valgus, cubitus valgus, where the apex is pointing towards the midline of the body, more towards the midline of the body. So normally also there is an apex which is created at the level of the elbow by the carrying angle, and this apex is pointing towards the body, but here the carrying angle is more than normal, so it goes in the favor of valgus. Exactly opposite would have been a varus deformity. If this is the trunk of the individual, all right, then if this is the arm, this is the forearm, if this kind of the condition is happening where the axis or the apex of this angle is pointing away from the midline of the body, then it would have been a varus deformity at the level of the elbow, that is cubitus varus. All right. Now, what is cubitus rectus? One of the options was cubitus rectus. So, what is cubitus rectus? When the axis of the forearm and axis of the arm is one line. That means there is no carrying angle which is created in between the two. The carrying angle is 0. That is cubitus rectus. All right. Now, this is something which you already are aware of. It is just the point of identification. Like in this image in particular, on the right side, we can very clearly see that this is the axis deviation, but on the left side, the axis deviation is slightly more. So, the carrying angle which is created at the level of the left elbow is higher in comparison to the right one. So, the left one is suffering from the cubitus valgus deformity. So, answer for this question is obvious, that is cubitus valgus deformity. Now, one thing which I have been quoting right from the beginning is that, both these varus or valgus abnormality at the level of elbow can only be demonstrated with the extended elbow. If the elbow is flexed to any degree, 5 degree, 10 degree, 20 degree, and there is an apical angulation or there is an apical deformity, then it is inconclusive until and unless the elbows are kept completely extended. So here also in this case, you can only say that it has moved into varus or valgus because the elbow is completely extended. All right. So one prerequisite which is required in order to identify the abnormality as varus or valgus or tag the abnormality as varus or valgus, that it has to be demonstrated only with the extended elbow. All right. If the elbow is slight amount of flexed, if there is a flexion deformity of the elbow and there is a apical deformity like this, no, you cannot jump onto the conclusion and can say that this is the cubitus varus or valgus deformity respectively. Hopefully everything is clear related to this question. Now, I hope that all of you have marked this answer correctly. All right. Next Now, this is the kind of the question which we have talked in the short form, like every time we are talking about the soft tissue injuries in the upper limb. Now, this is one thing which is very, very much obvious in any of the provided image, and there is a strong reason behind this abnormality too. So, as you can very clearly see, the topic that we are talking about, one is PAAR sign. The name of this sign is PAAR sign. All right. Point number two. What is this injury over here which is happening? It is injury to the biceps tendon. Actually, it is the rupture of the biceps tendon. Now, what happens? When there is a rupture of the long head of the biceps tendon from the coracoid process, as a result of which the entire biceps gets accumulated. The entire biceps muscle gets accumulated in the arm. And when the patient is asked to flex the elbow, then this accumulated biceps will be more prominent in comparison to the normal one. So, there will be an abnormal prominence of this biceps bulk on flexion of the elbow. Why we are correlating it with the cartoon character Popeye? Because in Popeye cartoon, on the intake of the spinach, there was over prominence of the biceps muscles. So, this is how the things are getting correlated. Alright. So, here we are having, or we can witness the abnormal prominence of the biceps bulk. This is the abnormal prominence of the biceps bulk on flexion of the elbow. Alright. It is because the long head of the biceps is ruptured, the tendon of the long head of the biceps is ruptured, and all the biceps is getting accumulated over there in the arm. Alright. So, this kind of a question is a straightforward question. Like, there is nothing which is required in the sort of a background. Alright. And this is the question which was asked for the first time in All India Examination 2019. It certainly got repeated after 1 or 2 years also. But in FMGE examination, I think it is for the first time or the second time this question has been asked. Alright. We always used to talk about this particular topic along with the mallet and the gamekeeper thumb. Alright. That is PAAR sign. Because there is always a strong reason for these kind of the questions to become apparent in your paper. Because these are a kind of the question which are going to have a certain answers without any confusion. Okay. So, hopefully everything is clear related to this PAAR sign and the biceps tendon injury. Then there was a question where, a diagrammatic representation of the patella was there. Then there was a patellar tendon that obviously it is going to be on the lower pole of the patella. Then we had the quadriceps over here in the proximal aspect, and there was a marking onto the superior pole of the patella that there is a pain and tenderness in the superior pole of the patella. What is the name of the bursitis over here? Obviously, it is prepatellar bursitis. Alright, that is suprapatellar bursitis, and the suprapatellar or the prepatellar bursitis is the feature of the housemaid knee. Now, these are the kind of one-liners, bursitis are the kind of one-liners that we talk about, because these are the kind of the question which are always going to be kept in your examination, either in the form of the one-liner or in the form of a diagrammatic representation as is being asked this time. Alright, like bursitis means like if there is a lateral epicondylitis, then this lateral epicondylitis is known by the name of tennis elbow. Lateral epicondylitis of the humerus. So, it is known by the name of tennis elbow. So, this is one thing. Second is medial epicondylitis of the elbow is known by the name of golfer elbow. Alright. The third one is student elbow. Now, student elbow is olecranon bursitis. Actually, this is the table where all the bursitis are being accumulated. Then there is prepatellar bursitis, or you can say suprapatellar bursitis, and this prepatellar bursitis is the feature, or it is known by the name of housemaid knee. Then it is often confused with infrapatellar bursitis. Alright, this infrapatellar bursitis is actually known by the name of clergyman knee. All these bursitis is the result of a repeated frictional assault or repeated frictional abuse to the surface of the tendon or the surface of the muscle, resulting in the formation of the bursa, which is getting inflamed, which gets swollen up and resulting in this painful condition known by the name of bursitis. Similarly, we have Weaver bottom. weaver bottom, which is ischial bursitis, and talar ankle. This is TAI, talar ankle, which is lateral malleolar bursitis. Lateral malleolar bursitis. All right. So hopefully you have marked this answer also correctly. We are not getting what exactly the kind of the question, but there was a image which was provided where the arrow was placed in the prepatellar region, and they have asked that what is the name of the bursitis which is responsible for the pain and tenderness in this particular region. It could have been asked in the form of either a simple prepatellar bursitis or in the form of a housemaid knee. All right. So this much about the orthopedic recall, which has been asked in the form of the question in this July 2023 examination for FMGE. The questions were relatively simple, except for the single one question that is about the trapezius abnormality. All the questions were the repeat questions. Out of 6, the questions that we have collected directly or indirectly related to the orthopedics, the 5 were direct repeats. All right. The 5 were the kind of the question which has been asked multiple of the time previously. So all the best for your future endeavors. Thank you so much for attendance.